All right, this lecture is going to talk about pediatric hematology. We're going to do a quick review of the hematological system and its function so that as we move through the rest of this lecture, you'll have a jogged memory about the different parts of your blood, your hemoglobin, and the hematopoietic organs, which include bone marrow and the lymphatic system, spleen and liver, as well as the thymus. So your blood is made up of two different elements. You have your plasma and your formed elements, and they're each about half of the volume of your blood. When we talk about formed elements, what's included in that is red blood cells, white blood cells, and platelets. Most of what we talk about today will focus on those formed elements as well as the hematopoietic organs, or those organs in your body that make different parts of your blood. The myeloid tissue, otherwise known as bone marrow, is really important in the making of blood cells, and the lymphatic system is really important in the making of white blood cells as well as some of your immunologic function. The spleen and liver help to filter blood and also create some blood cells themselves. So you should remember the function of these cells. Red blood cells have a lot of different functions, but one of the main ones is carrying oxygen to the tissues throughout your body. And then white blood cells fight infection, and platelets help with clotting. If you need a better review, your book has a more in-depth review that I encourage you to read before progressing through these lectures. Coagulation is also important to be familiar with, and I won't go into gritty details about the cascade, but be aware that factors circulate in the blood as a significant part of the coagulation cascade. The endothelium or endothelial cells produce clotting factors 3 and 8, while most clotting factors, including factors 7, 9, and 10, are produced in the liver. And these factors become important when we are talking about bleeding disorders. In terms of assessment, one of the first things that you think about is a complete blood count with differential. The differential is a manual count by someone in the lab that looks at all the different types of white blood cells and red blood cells and gives you a more detailed view. And this can give you a lot of information about someone's hematologic function. So it's important to understand the different parts and also understand that the ranges we accept are based on age. So a normal CBC for a 6-month-old is not the same as the CBC for a 12-year-old. And most hospital labs do account for this in their EMR, but please be aware that they do change over time with age. We will also get a history and physical assessment where we will look at things like color, such as pallor or bruising. Are there lots of hematomas, petechiae, which are those pinpoint type bruises. We're going to be looking at cap refill, temperature, enlarged lymph nodes. All those things can be important in assessing hematologic function. Really inquiring of the caregiver, has the child's energy or activity level changed recently and in what timeline? And then also looking at growth patterns for any unexpected gains or losses. Let's begin by talking about iron deficiency anemia. Iron deficiency anemia is defined as inadequate supply or loss of iron. So you can have iron deficiency anemia from several different causes, such as not getting adequate dietary iron, or you could have a loss of iron, like you would see in gross blood loss, for example. The manifestations of iron deficiency anemia are really the same independent of the cause, but the management, treatment, and nursing considerations are different. So it's really important to understand what is causing the iron deficiency anemia so that we can treat it properly. Iron deficiency anemia is the most prevalent nutrition-related disorder worldwide and the most common hematological disorder among pediatric clients globally. We generally start seeing it in patients around 9 to about 24 months, and this is for a few reasons. One, maternal iron stores are transferred to the fetus, and they only last about 5 to 6 months, and then the infant needs dietary supplementation. And two, once babies transition to solid food, they get picky, if you recall. So getting a toddler to eat is hard enough, and getting adequate iron is even harder. So now we have iron-fortified formula. We have iron-fortified baby cereals that are recommended around 5 to 6 months. For breastfed babies, we do recommend iron supplementation. Adolescents also have an increased risk due to their rapid growth and poor eating habits. The patho here is pretty simple. Iron is required for hemoglobin production, and hemoglobin is what carries oxygen to your tissues. So the main effect that you see in iron deficiency anemia is decreased hemoglobin level, which leads to decreased oxygen capacity. Symptoms are often very insidious or of slow onset, and they're very much related to the severity of the anemia. So really, kids can be either underweight or overweight. If they're overweight, that anemia may actually be from excessive milk consumption. Children with anemia from excessive milk consumption can become anemic for two different reasons. One, cow's milk is a poor source of iron and is often given in exclusion to other table food. It's very calorie dense and filling, so they will drink excessive amounts and then they won't eat any solid food that is a better source of iron. The second reason is that approximately half of infants that drink cow's milk actually have increased blood loss in their stool. And it's not necessarily allergic, but it's a sensitivity or reaction to it, and this can lead to iron deficiency anemia as well. So the combination of these two things from overconsumption of cow's milk can cause the child to be overweight. And this is why we now recommend only 16 to 24 ounces of cow's milk for a child over the age of 1. And obviously children under the age of 1 should not be given cow's milk at all. Other signs you may see include irritability, tachycardia because they have decreased oxygen carrying capacity, fatigue, glossitis, which is a swollen tongue, or koilonychia, which are spoon-shaped fingernails, which you'll only see in really, really severe cases. We do CBC screens for all children between 9 to 12 months, and this can often suffice in screening for iron deficiency anemia, but serum ferritin levels and other iron studies can provide some additional information if needed. Therapeutic management for iron deficiency anemia includes maximizing iron-rich foods, so teaching parents what foods are rich in iron, such as green leafy vegetables, and some red meat can be rich in iron. There's actually some newer studies coming out about cooking in cast iron skillets and the amount of iron that is transferred that way. So that can be a really creative way to add iron to foods that otherwise might not have any. And then iron supplementation is kind of an obvious choice. So the first step of management is always prevention. And when kids come in for their well visits, education should be provided on diet, asking the family how the child is eating, finding out about any iron supplementation they may already be taking. We do want to consider financial disparities related to the cost of food and be prepared to provide budget-friendly options like eggs and beans and lentils. It's also important to educate parents regarding limiting cow's milk to 16 to 24 ounces per day. Teaching will center around how to give iron supplements and also providing information on side effects and things to look for when a child is on iron. So iron does stain the teeth and clothing if you have ever seen it. It's very darkly colored and it smells pretty awful. So it's got that going for it. An iron supplement should be given in between meals because it actually has increased absorption when the hydrochloric acid is highest. And it's also really good to administer with juice or fruit for that same reason. If the child is on an adequate dose, their stools will probably turn a kind of tarry green-black color, and that's actually a sign that they're getting adequate intake. And if they don't look tarry or green or black, there's a chance that the parent is either not giving the full dose as prescribed or it's not high enough. So we're going to move on now to sickle cell. Sickle cell is an inherited disorder that is most common in African Americans. In the U.S., infants are universally screened for sickle cell on their newborn screen, similar to cystic fibrosis. The rate of asymptomatic carriers is about 8% in the U.S. and 40% in West Africa. And the reason that it's so high in that population is due to its selective protection against malaria. We do see sickle cell anemia in some Mediterranean populations as well, and you can see it in a person of any race, but it is most common in the U.S. among African Americans. There are several different types, such as sickle thalassemia and sickle cell C, but we're going to focus on the homozygous process for the purposes of this lecture. So in sickle cell anemia, hemoglobin A is partly or completely replaced by abnormally sickled cells called hemoglobin S for sickled, right? So you can see in this image the healthy cell with movement on the left and the sickled cell on the right and how it clumps in those blood vessels. The cells have a much shorter lifespan than healthy RBCs, so there are also fewer circulating in clients who have sickle cell anemia. About 35 to 45% of the total hemoglobin in a sickle cell carrier is hemoglobin S, and so they are essentially asymptomatic. But in those who inherit the gene from both parents, almost all of their cells will be sickled. So I mentioned that partial or complete replacement of normal hemoglobin with abnormal hemoglobin. And so why does this cause a problem? These sickled cells actually obstruct capillary blood flow, and that's really what leads to all of the clinical manifestations and sequelae of sickle cell. These microscopic obstructions will lead to engorgement and tissue ischemia and hypoxia, and the two biggest triggers for this vaso-occlusion include hypoxia and dehydration. So think about the effects of low fluid volume in a vessel, for example, and you can kind of visualize how that would create more opportunity for these cells to stick together due to the viscosity and just more crowding. So this is one of the primary ways that we try to prevent a crisis, avoiding the triggers, extreme temperatures, etc. These patients can also get large tissue infarcts. So you can not only get like these light microscopic obstructions, but they can actually get infarctions in their large organs. The damaged tissues and organs can actually lead to impaired function. So one thing we talk about in sickle cell patients is that they often have splenic sequestration, where their spleen basically gets occluded and stops working. So they may have a splenectomy in an early age, and they're actually considered asplenic, or not having a functioning spleen, after the age of 6 for all sickle cell patients. And so what this results in is decreased immunity, which leads to increased infections and risk for infection. So vaso-occlusion is one of the primary manifestations, and it sort of leads to everything else, as I mentioned. And we'll talk a little bit about vaso-occlusive crises and pain. We do have that splenic infarction, which leads to either the spleen being removed or what we call functional asplenia, where the spleen remains, but we know it's not functioning. We can have hepatomegaly from occlusions in the liver and possible development of gallstones. We can also have kidney abnormalities. There's also a very high risk for stroke in these patients and something called acute chest. And this is because thromboembolism can occur and move to the lungs or the brain. We can also have signs and symptoms of anemia that can be present, like fatigue and weakness and pallor. You typically don't see these symptoms in the first few months of life because for the first 90 days, the infant has the presence of fetal hemoglobin, which won't be sickled. So we don't start seeing manifestations from this until around 3 months of age. And by then, we will have that newborn screen back. So we would be able to begin management prior to symptoms, which is really important. So sickle cell crisis, the precipitating factors of this can be trauma, infection, stress, dehydration, or hypoxia. You can have this vaso-occlusive crisis, which is extremely painful, and they're really the most common type of sickle cell crisis. Patients will usually present with some fever, pain, swelling, localized to a joint or other areas. They can have very high pain needs during these occlusive crises. They can also have splenic sequestration, which can be life-threatening if not recognized early because the blood actually begins to pool in the spleen. So when you look at signs and symptoms for splenic sequestration, they can have profound anemia from that blood pooling, hypovolemia, which can lead to shock. So how do we manage these patients? Well, the priority is to prevent the sickling in the first place. Sound familiar? Prevention, 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 and treat those medical emergencies. So to prevent sickling, we're going to do a lot of education and coaching with these patients to prevent hypoxia, stress, all of those things on the previous slide, and dehydration. We are really encouraging these patients to drink to stay hydrated. High oxygen demand activities should be avoided to avoid hypoxia, so they probably shouldn't do 1-hour HIIT classes. We want to prevent extreme heat or extreme cold. So these students may need letters that they can't stand outside in the cold waiting for the bus, for example, or go out in extreme heat for lunch or recess because of the likelihood of sickling. Teaching parents and kids to recognize medical emergencies and when they need to come to the ER is important. They'll often be on hydroxyurea and folic acid to prevent pain crises and to encourage hemoglobin production. These patients can actually receive stem cell transplants, which would effectively cure them of sickle cell. Obviously, stem cell transplants come with their own risks and their own lifelong side effects, but it is curative. However, candidates cannot have any organ damage prior to the procedure. From the nursing management standpoint, you really want to monitor growth. You want to provide patient education like we talked about. When you have a patient admitted for a vaso-occlusive crisis, you want to assess their pain frequently and hydrate them. That's really what we do for these vaso-occlusive crises. You manage pain and you hydrate, hydrate, hydrate. And in the meantime, we are also monitoring them for signs of thromboembolism or ischemia. Beta thalassemia is a single gene inherited autosomal disorder, that's a mouthful, that impairs production of hemoglobin. So as with sickle cell anemia, this condition is also included on newborn screens in the US. There are no direct risk factors for beta thal except for genetic ones. So 2 carrier parents have a 25% chance of passing the disease onto their child. Lab tests will show low hemoglobin, usually less than 7 grams per deciliter, and a test called hemoglobin electrophoresis will show the absence of the beta globin chains. There are 4 main types, but the most common is beta thalassemia major or Cooley anemia. Manifestations of beta thal include typical signs of anemia, pallor, feeding problems, poor weight gain, irritability, possible developmental delays. These kids need regular blood transfusions to keep their hemoglobin stable, and so chelation therapy may also be required to eliminate the extra iron that accumulates from these transfusions. We'll also educate them usually to not have any iron supplementation or foods that are very high in iron for that reason. As with sickle cell disease, some of these patients may require splenectomies and can also receive stem cell transplants as a curative treatment. So there are a lot of parallels here with sickle cell anemia. in regards to how we are caring for these patients and how we can help treat the problem. There is also a high risk of infection in these patients, and education will center on therapy compliance, psychosocial and family support, and then monitoring for safety during blood transfusions. Hemophilia is a group of X-linked recessive bleeding disorders where your clotting factors are low or missing. Severity of this disease depends on the amount of factor that is circulating in the blood. The most common type is hemophilia A, which results as a deficiency of factor VIII. The other 20% are hemophilia B, also known as Christmas disease, where factor IX is deficient. Now keep in mind that since this is an X-linked disorder, males are more likely to have the disease since they only inherit one X chromosome. And in order for a female to have it, she must inherit two X chromosomes that are affected, so her father must have hemophilia and her mother must also be a carrier. So factor is produced in the liver and is required for thrombin formation in the blood. One of the first signs you will see is delayed clotting from early procedures in newborns, such as heel sticks for a newborn screen or circumcisions. These patients will also experience joint stiffness and pain, impaired mobility, easy bruising, and activity intolerance. The platelet counts, if we were to draw labs, are actually normal in these patients. It's important to remember. The issue lies with the partial thromboplastin time, or APTT, which will be prolonged. Factor-specific assays can also be run to determine which deficiency they have. So in order to treat the deficiency, we have to replace the factor, and this is done by IV infusion after an injury or incident that may cause prolonged bleeding. It's also given in preparation for any invasive procedures ahead of time to minimize complications. So one of the more severe complications of hemophilia is bleeding into the joints, or hemarthrosis, and this can follow even mild trauma or even no trauma at all. Signs would include bruising, decreased mobility, swelling, and pain, and this is most often seen in the knees, elbows, and ankles. Recurrent joint bleeds can cause long-term effects due to damage to the cartilage. There are some newer therapies being developed, but as of right now, they're pretty cost prohibitive. Preventing bleeding in the first place is ideal, as well as early intervention if any injuries occur. We do provide genetic counseling since this is an inherited disorder. And then these pictures included are courtesy of Dr. Spangler, who was the previous course coordinator whose son Henry has hemophilia. And as you can imagine, her lecture on this subject was far more thorough, but you can see from the photos how easily minor injuries can lead to bleeding. I believe the middle photo was his first joint involvement, and so they were marking the hematoma there with marker to monitor its spread. So this concludes the lecture on hematology. Have a great day.